Hello, David.
Yeah. Hello. Yeah, thanks for taking the call. My question, it's about prostate cancer.
Okay.
And I'll just tell you real quickly my situation. I was diagnosed in late 2020. I think I had a PSA somewhere in the neighborhood of 60, really high.
Yeah.
Yeah, after doing a biopsy, it was determined that the best course of action was just to remove the prostate, which they did in March of 2021. They did not detect any breach of the prostate with cancer. They checked lymph nodes, no cancer. So the expectation was that my PSA would go down to 0. However, it didn't. It was very, very low, but then it just started creeping up. Then in 2024, it was decided to do radiation therapy, which I did, and ended that in about January of 2025. Well, coincident with that, they put me on Orgovix to kill the testosterone. And ever since the radiation and taking the Orgovix, my PSA tests have all been non-detectable.
Good.
I'm due to be off Orgovix. This is my last month of being on that drug. And then it's kind of like what I've heard from my oncologist. Well, we wait and see what happens. Mm-hmm. And the reason I'm calling you is you had mentioned in a prior show that senescent cells are kind of a big issue with kind of but in dealing with prostate cancer.
Yes, and after the radiation therapy, sure.
Yes, after radiation therapy is the way you stated it, yes.
I was curious about the senescent cell impact. Mm-hmm. Yeah, for one thing, we believe that one of the primary triggers for prostate cancer as well as kidney cancer is the buildup of senescent cells within the organ, within the gland. We know from autopsy studies that the older people get, the higher the load of senescent cells in the testicles, in the prostate, in the adrenal glands, in the thyroid, in the hypothalamus, the pituitary, all of our glandular structures that are making hormones accumulate senescent cells faster than our muscle or our skin. So they are more susceptible to senescent cell load. And the chemicals they kick out that they produce, we call it the SASP, the senescence-associated secretory phenotype. These chemicals produced by senescent cells are pro-cancer. They help you to form cancers, and they help you to maintain and grow cancers faster and make them spread quicker. So the theory is that if we go through people in their 40s and 50s and lower their senescent cell load, we should decrease the incidence of all cancers. They should have less risk of getting colon cancer and prostate cancer and pancreatic cancer and lung cancer. I mean, if that turns out to be true, it would be pretty wonderful.
Yeah.
So I am a big booster of, let's lower the senescent cell load as much as we reasonably can. But we also know that chemotherapy and radiation therapy, while they kill most of the tumors, they also create a whole new host of senescent cells.
Yeah.
Senescent cells are triggered when a cell is damaged but not quite killed. Mm-hmm. And it then can convert into a senescent state in which it's now kicking out chemicals that promotes the growth and formation of new cancers. Mm-hmm. And so we believe that this may be why people that have had one cancer are much higher incidence of getting second and third and fourth cancers later on in their life. In part because A, they got the first cancer. That told us their immune system was not very good at finding and killing cancer. And second, when we treat them with radiation or chemo, we're making all kinds of new senescent cells and raising their load even higher, which sets up their cellular environment to promote more cancers. So the new theory is that A, reducing senescent cell load before people have cancer should lower their risk of getting cancer later. Secondly, after they've had a cancer and been treated with chemo or radiation, we should probably treat their senescent cell load again to lower their risk of getting a new cancer or a reoccurrence of a previous cancer. So that's really what we're looking at with someone like you. You know, even when they did your first prostatectomy, they thought they got it all. They didn't. The fact that your PSA was still present at all said you still had prostate tissue hiding somewhere. So it had already spread. We just didn't know where yet. And then later, as the PSA started rising again, and they did the radiation therapy, okay, now we've kind of shotgunned, hopefully to kill all the cancer again. So my philosophy is, in someone in your situation, A, I want to see where your senescent load is now. B, I want to treat you aggressively and lower that senescent cell load as far as I can. Unfortunately, the new senescent cell test that we have just developed and we're starting to use this coming week is not approved by the FDA for use in the general public. It's only for use in my research group, which is my patient population. So the only way I can test you right now is if you were a patient at Longevity Medical Clinic. Now, I'm working with the regulatory folks. My hope is a year from now, I'll at least get a tentative approval so I can offer it to non-patients or to other clinics. But right now, it's only within our clinic.